Should we be treating AFib with RVR in the field? If y'all remember back to episode 81, we reviewed a study by Fornage and colleagues that suggested maybe we should. That was a propensity match study of just under 5,000 adults treated mostly with calcium channel blockers and a couple with beta blockers, where they found a 2.5%, that was statistically significant, 2.5% mortality benefit with treatment. That calculates to a number needed to treat, or NNT, of 40, meaning for every 40 patients you treat, you save one life. And that's roughly in the range of aspirin use for STEMI. Now, it turns out they also found a 4% decrease in hospital admission and, not surprisingly, a 22% increase in EMS rate control. Now, 84% of those who were treated with anything at all were treated with diltiazem. And as the authors point out, that means this was largely a study of diltiazem. And diltiazem, while a really safe medication, can have some adverse events, and certainly hypotension is among the more obvious concerns. Indeed, this study, the Fornage study, found a 3% increase in hypotension in the treated group. Remember, though, that even with that added hypotension, mortality and admission were both decreased with treatment. So perhaps the question isn't really should we be treating, but is there a way we can treat more safely, maybe with less hypotension? Seems like a good question. Fortunately, there's a new paper out that compares pretreatment with calcium prior to giving DILT for AFib. The hope here is that it might cause less hypotension. And as an added bonus for my nerdy friends, we're going to talk a little about Bayes, okay, maybe a lot, about a Bayesian approach that can help us decide how to use the results of this paper in our own clinical practice. So stick around because the Valley of Bayes awaits.
Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, the one where we shine the bright light of science on the darkness of current EMS clinical practice. Now, before we dive into the specifics of this paper, let me give y'all a warning. A nerd alert, if you will. I'm reading a book right now that Rimley gave me, and it's called Everything is Predictable: How Bayesian Statistics Explain Our World, and it was written by Tom Chivers. Now, my warning is that I'm going to be using this paper to discuss Bayesian thinking primarily because I'm reading this book and another one that Rimley gave me about the theory that would not die, again about Bayes. So Bayes is just kind of on my mind. Now, we've talked about Bayes before, including a great interview we did with Rimley and CJ Winkler in episode 82 when we were at the Texas NMSP conference. That's the one where we asked ChatGPT to explain Bayes to the good Dr. Winkler like he was an East Texas redneck. That was a lot of fun. At least it was a lot of fun for me. We also discussed the wonderful Bayesian analysis that Dr. Perkins included in his landmark Paramedic 2 trial of epinephrine in cardiac arrest. Now, y'all know I love that paper, talk about it all the time. One of the reasons I liked it so much was because of this Bayesian analysis. So I mention these things because I can feel that y'all want to go back and listen to some more of EMS Lighthouse. But just in case you, I don't know, for some strange reason, just in case you prefer to get on with it, let me give you a brief description about this Bayes stuff. Thomas Bayes described both a theory and an equation. Now, the theory says something pretty straightforward. It says that we can apply new knowledge or evidence to what we already know, and then you either add to or subtract from that prior knowledge. This is really appealing to me because it reflects how we think about common things, or at least how I think about common things. Let's give an example here. Let's say you're trying to decide whether to take an umbrella to work. You're inside and you're looking out. You see that it's cloudy, but it's not raining. You know that sometimes when it's cloudy, it rains, but sometimes when it's cloudy, it doesn't. You're looking for some additional information. You look out the window and you see people walking around carrying umbrellas. Now, seeing all of those other people with their umbrellas, that adds to your prior knowledge of the cloudy sky, and you decide you're going to bring an umbrella to work. We do things like this every day by adding new information to what we already know in order to make better decisions. Now, a more simple way of saying this is that you form a belief and then you gather additional information. You then use that additional information to adjust your prior belief. Bayesians call that initial belief a prior or a pretest probability. They call your adjusted belief, the thing that you make with the new information, they call that a posterior or a post-test probability. Bayesian statistics lets you use the results of a study or new evidence or new data to calculate specific post-test probabilities, which helps us make better clinical decisions. Let's use Dr. Perkins' Bayesian analysis in Paramedic 2 as another example of the types of questions we can answer with Bayes. Now, he used the results of all of the prior studies on epinephrine in cardiac arrest, along with the results of his own Paramedic 2 trial, and then calculated that there is only a 1.9% chance that epinephrine, when compared to placebo, will result in at least 1% or greater improvement in neurologically intact survival from cardiac arrest. Now, as it turns out, I find this to be a much more clinically useful way of thinking about the study results. With that in mind, let's get back to whether we can do something to prevent hypotension when using diltiazem for the treatment of AFib with RVR. Now, as y'all know, diltiazem is a calcium channel blocker. Without doing too deep a dive on calcium channel physiology, let's just say that calcium channel blockers can cause some peripheral vasodilation. Now, this is most prevalent in the class of calcium channel blockers known as dihydropyridines. Examples of these would be amlodipine or nifedipine or nicardipine. Now, turns out calcium channel blockers can also decrease AV conductivity, and that is more prevalent in the non-dihydropyridine blockers, things like verapamil or diltiazem. Now, although diltiazem causes less vasodilation than a dihydropyridine like nifedipine, it can still cause some, and that vasodilation, particularly in frail elderly patients, can lead to hypotension. Now, AFib with RVR is already prone to hypotension because the rapid ventricular rate decreases diastolic filling time, which decreases preload, which can further decrease cardiac output. Further vasodilation from calcium channel blockers can add to this and can cause more hypotension. So maybe pretreating with calcium can blunt the diltiazem-induced vasodilation and maybe lead to less hypotension. Now, of course, it can do that. Maybe that same blunting effect could result in, say, less AV blocking effect, which could result in less rate reduction. Now, the degree to which either of these things actually occurs is kind of unclear. We just don't know. That's the reason we need another study. Another way of saying this is that our priors on the impact of calcium treatment, they're equivocal. They don't really tell us one way or the other. They're neutral. In other words, things could go either way. It's a 50-50 shot, if you will. Well, 50-50 is a probability. It means we don't know. That's a neutral prior. So fortunately, we have some new evidence that we can use now to adjust that neutral prior, the 50-50 shot before this trial, to make a more informed posterior probability. In other words, to make a better decision on how likely calcium pretreatment is to work and whether we should use it or not. So let's get to the paper. This paper is by Dr. Oz and his colleagues, and I hope I'm pronouncing his name right. If I'm not, my apologies. The title is Reducing Diltiazem-Related Hypotension and Atrial Fibrillation, the Role of Pretreatment with IV Calcium. Now, it's published in February of this year in the American Journal of Emergency Medicine. It was a nice study. It was pretty well done. It was a single-center emergency department-based trial done in Istanbul, Turkey. Let's hit the PICO question, shall we? So we mentioned the methods on this placebo-controlled, double-blinded, randomized trial. Now, these are all good things. We like these. They enrolled adults over the age of 18 who showed up in the ER with either AFib or a flutter and a heart rate greater than or equal to 120 and a systolic blood pressure greater than or equal to 90. Now, they excluded the normal patients, the patients you would expect them to exclude, the pregnant patients, the ones for whom you don't want to give a rate-blocking drug, like, say, third-degree heart block or Wolff-Parkinson-White syndrome or hypercalcemia. And they also wanted to exclude those patients who had already gotten a calcium channel blocker or a beta blocker at the same emergency department visit. Now, they had 2 intervention arms and a control arm. All 3 of the arms got diltiazem at the same dose, 0.25 milligrams per kilogram, slow IV push. Now, the intervention arms also got pre-treated with calcium, either 90 milligrams of elemental calcium or 180 milligrams of elemental calcium before they got the diltiazem. And then the control arm got a similar volume of normal saline. Now, at this point, I think it's probably useful to say what I mean when I say elemental calcium. Now, we don't have elemental calcium on the ambulance. We either have calcium gluconate or, more likely, calcium chloride. Now, as y'all know, calcium chloride comes in a concentration of 1 gram in 10 milliliters. That is 1 gram of calcium chloride, to be clear, not 1 gram of elemental calcium. To get how much elemental calcium you need, you got to get the chloride out of there. So if you back out the chloride molecule from that, what you're going to find is about 273 milligrams of elemental calcium. So in this study, when they say they're using 90 milligrams or 180 milligrams of calcium, just think you're using less than one of the pre-filled syringes that we typically see, the 10% calcium chloride. That's 273 milligrams of what we would typically give. All right, so let's go back to this PICO question. There are 3 arms. 2 of them had calcium, either 90 milligrams or 180 milligrams, and then the control arm had normal saline. Let's talk outcomes. Their primary outcome was the change in systolic blood pressure at 5, 10, and 15 minutes compared to baseline. Now, they measured this as a continuous variable, and it's not what I would have preferred. What I would have preferred is the proportion of patients who experienced hypotension. I think that's easier to understand. It's certainly easier to talk about, and it's more about what we're worried about. But that's not what they measured. They measured it as a continuous variable. Now, secondary outcomes included the change in heart rate, the need for additional dosing of diltiazem, and the occurrence of composite adverse events. Composite adverse events means either hypotension or bradycardia or other badness. Now, if you really got to know, when they're looking for redose of diltiazem, all of their redosed doses were at 0.35 milligrams per kilogram, kind of standard practice. Now, they talk about a power calculation they did, and they figured out they'd need 210 patients overall. Because this is a nerdy podcast, let's talk about their stats. So they did a chi-square test for their categorical data, and they used either a Krukes-Wallace or a Mann-Whitney test for continuous data, depending on whether the data was normally distributed or not. All right, y'all. For any EMS fellows that are out there who might be thinking about an upcoming board exam, maybe a high-stakes exam, I want y'all to hear me really clear on this next bit. They used a Bonferroni correction. Okay, so what's the big deal about a Bonferroni correction? Well, if you just happen to see a hypothetical question on, say, a hypothetical exam about how to hypothetically correct for the very, very non-hypothetical tendency of multiple comparisons to find a positive answer by chance alone, then you better be looking for an answer that says Bonferroni. Basically, what we know here is that if you throw a bunch of shit at the wall and try to measure whether any of it's going to stick, the more shit you throw, the more likely it is that some of it will stick. Turns out it's the same thing with doing a study where you're doing multiple comparisons. The more comparisons you do, the more likely you're going to find one that has that beautiful p-value of less than 0.05. So Bonferroni, what it does is it basically lowers the p-value that you need to show significance, and your new p-value is 0.05. Let's say that's what you were going to use for significance to begin with, and it divides it by the number of comparisons. So Bonferroni is your friend. Look for it on, say, a hypothetical multiple choice high stakes exam near you. Hypothetically, of course. And I swear, don't you ever say I didn't help you with your board exams. I'm here. I try to help. I'm here for you. So we talked about the PICO question. We talked about the methods. We talked about the stats. We talked about Bonferroni, because you got to remember that. Let's get into the results. So they screened and consented 421 patients, all had AFib RVR. Now, they excluded 204 for various pre-specified reasons. You can see them up on the screen if you're watching YouTube. And that left us with 217 patients that they randomized. Now, as you would hope, the randomization resulted in similar baseline characteristics between the two groups. Now, the main results are honestly a bit of a mess because of that decision they made with their primary outcome. They chose to report the differences as continuous variables and only compared the difference between baseline and different times within the various treatment arms. In other words, if you're watching on YouTube, you can look at this table. What you see is the change in heart rate and systolic blood pressure for patients who were treated with placebo. So what was the difference at 5 minutes, at 10 minutes, at 15? And then was that a statistical difference? They showed the same thing for 90 milligrams, the same thing for 180. But what they didn't do, unfortunately, is compare the reduction that you saw between the two intervention arms and the control arm. You know, like you probably expected them to at the beginning of the paper. Now, there is still some value here, so let's press on. We're going to find the value. Now, y'all know I'm a sucker for data visualizations, even if the data visualizations are simple line plots. And although simple line plots from this paper don't really offer much insight, I'm going to show them anyway. And honestly, it's because, well, they have nice colors, and they show diltiazem effectively lowers the heart rate despite calcium pretreatment. And it also shows that calcium pretreatment seems to blunt some of the decrease in systolic blood pressure. That's good, and that's pretty much the majority of the paper. Now, y'all know I complained earlier about the authors not using change in systolic blood pressure as a dichotomous outcome, meaning they showed the amount of change, but not whether there was hypotension or not. Well, they do sort of provide me just a little bit of what I want in Table 4. The bottom line here in Table 4 is they're telling us that there wasn't a significant difference in the need for redosing with DILT. There's less than 15% redosing regardless of the group you're in. And they also found no significant difference in composite adverse events. But one of the adverse events, in fact, the most common adverse event in this test was hypotension, as in the thing that at least I care about most. And although they ran their statistical test that shows no difference on composite adverse events rather than on each component of the adverse events separately like I would have wanted to, at least they provide some numbers here so I can have some fun running some Bayesian calculations to try to figure out what to do with these numbers. Now, the raw numbers show that the proportion of patients experiencing hypotension, and they define that as a systolic less than 90, well, it decreased from 7% with placebo down to 1% in the 180 milligram of calcium arm. Now, this amounts to a 6% absolute reduction, that is 7% minus 1%, a 6% absolute reduction in the risk of hypotension between placebo and the 180 milligram dose of calcium. That's the thing that I'm really more interested in. So, their conclusion. They said that pretreating with 180 milligrams of elemental calcium can effectively prevent diltiazem-induced hypotension without inhibiting the ability to achieve rate control. And that's nice and all, and I guess it's more or less supported by the study, but it's not great evidence of what I wanted to know, what I cared about. And I just can't believe they weren't writing this paper for me, so it's kind of shocking. So what is it that I cared about? What I wanted to know and what I need to know when I'm deciding whether to pre-treat with calcium or whether to, say, implement a protocol for my paramedics to pre-treat with calcium in order to avoid hypotension. What I want to know is how likely is it that pretreatment will actually avoid hypotension more than placebo? That's the question I needed answered before I put this into my EMS protocols. So fortunately, given the data that was in the paper, particularly in Table 4, I think a Bayesian approach to this question can offer some help. But first, I want to rephrase the clinical question to more clearly express what I want to know. So here we go. How likely is it that using 180 milligrams of elemental calcium before giving DILT for the treatment of AFib with RVR will result in at least the minimum clinically important difference in the occurrence of hypotension as compared to placebo? What's this minimum clinically important difference thing? Well, that is the smallest amount of difference that would justify adopting calcium pretreatment. Now, there is no generally accepted MCID, that's minimum clinically important difference, for this topic like there are for some others, so I had to unofficially figure one out by comparison or consensus. So what does that mean? It means I called some friends. I asked some fellow EMS physicians the question here. And thanks to the Guild for coming through one more time with timely expert opinion. Y'all are always so good about answering my stupid-ass questions at random times. You are living proof that Signal is not just for sharing national defense secrets. So this consensus expert opinion, what was it? What did it say the minimum clinically important difference was in the treatment of AFib RVR? Well, the Guild felt they needed to see a 10% absolute reduction in the occurrence of hypotension with calcium compared to placebo before they felt like they would adopt it in their practice. Now, I pressed them on this, and I said, I want you to tell me what that difference would be as a continuous variable, because I wanted to compare it to what this study showed. Well, they pointed out, as I think y'all may be figuring out, that's a silly way to think about this. And before they gave in and said, okay, fine, we want to see a 20 millimeter mercury difference in systolic between placebo and calcium. Oh, and just because they couldn't help themselves, they said, yeah, there's that silly 20 millimeter difference, but what we really care about is what does the patient look like? Great. That's wonderful. It's not really the question I'm trying to answer here, but it is another reason that using the occurrence or not of hypotension would have been a much better primary outcome. So, With that MCID, a 10% difference in absolute rate reduction, I did some quick Bayesian calculations to find out, given neutral priors of there being no difference, and the results that I pulled from the data tables in this paper, I calculated the posterior probability of calcium pretreatment causing at least 10% or more reduction in hypotension compared to placebo. And when I say I did some quick calculations, I mean, of course, I asked ChatGPT and I confirmed it with Claude. Now, as an interesting side quest, I first discovered differences in the results that those two models gave me. Those differences and why ChatGPT and Claude were disagreeing, that threatened to pull me into a really, really deep, dark rabbit hole. But fortunately, my daughter, Sydney, reminded me that this podcast wasn't going to publish itself, and I need to get my fat ass back to work. So if y'all are thanking somebody for this, you need to thank Sydney. And speaking of Sydney, I got to brag about Sydney and I got to congratulate her. She just graduated last week with her master's degree in epidemiology from the University of North Texas Health Science Center right here in Fort Worth. And as an added bonus, the day before she graduated, she found out she was accepted into their PhD program. Now, what does that mean? That means my poor wife is going to have to deal with two Dr. Jarvises in the family, as though one weren't bad enough. So now back to the models. After getting both models sorted out, turns out they had some methodologic differences. They weren't solving the problem the same way. Had to get them back on the same page. But once we did that, they agreed that there was between a 10 and 12% posterior probability of achieving the MCID given the results of this trial. Ouch. That sounded much less impressive than saying there was a statistically significant drop in SBP with placebo, but not with 180 milligrams of calcium. But it's a way better answer to the question that we actually have. Now, if you're watching this on YouTube, you're looking in the show notes, you're going to see I've included a bell curve looking thing here. That's the distribution of probabilities around the difference. The little red dotted line there, that's marked PARR greater than or equal to 10. That's saying the probability of an absolute risk reduction of at least 10%. Well, if you look at where that line is drawn through and you look at the overall area under the curve, what that's telling us is that line and things to the right of it is the probability of seeing that result or greater. And the bottom line, it's 9.8%. That's not very high. Now, when I ask my friendly LLMs to calculate the probability of seeing, say, a 20 millimeter of mercury or less difference in SBP when you're looking at this as a continuous variable, because that's the number that my friends told me was a minimum clinically important difference if we insisted on looking at it as a continuous variable. Well, what does it say there? It says just as unimpressive a result, 11% probability of seeing 20 millimeter or greater. All right, so not great. But you say a 10% absolute reduction in hypotension, that's subjective. And honestly, I just don't agree with the guild. I think they're smoking crack. I think it's either way too high or way too low a bar. I think it should be 5%. Or maybe you think it should be 15%. Well, don't worry, y'all, because Papa Bays has got you. So you can actually run sensitivity analysis using whatever MCID you think is appropriate. The more those agree, the stronger your evidence and confidence in the results will be. So let's take a look at some of those. And if you're on YouTube, you can see them right here, all the different distributions. Now, there is a 51.7% probability, just slightly more than even chance, that calcium pretreatment will lead to at least a 5% reduction in hypotension. So if you think the MCID for prevention of hypotension is 5%, then you're in luck. There's a better than even chance You'll see that using calcium. Now, the probability, that 51.7%, the really nice one, that drops down to 0.8% probability of seeing at least a 15% reduction, if that's the value you think. And if you think the bar is too low and you got to see a 20% reduction, well, there is a 0.0% probability of that happening. Now, these things go together to suggest, when taken together, there probably isn't a huge effect here. Now, all of this is fine and well, Jeff, but what the hell is the point? Why did you take us on this little journey through the valley of the nerds, you might ask? I can hear you. And honestly, that's kind of a fair question. I brought up Bayes because I think it gives us additional insight into how to interpret the study and how to make clinical decisions based on it. Bayesian reasoning is particularly well suited for doing useful things just like this. Now, I would argue that Bayesian reasoning is more of what we want to know than knowing how many times out of 100 we would see similar or larger results if there was truly no difference between the treatment arms. You may be wondering, why the hell would I want to know how many times we would see similar or larger results if there was really no difference? Well, because that's what a p-value actually tells us. The p-value is not contrary to popular opinion, and certainly not what I thought it used to mean, which is exactly this. It is not the odds of seeing a study's results by chance alone. Nope. Turns out that is not what it says. And it almost certainly isn't telling us what I actually want to know, which is how likely is it that these results are true, that these results are accurate, and therefore going to be useful in my practice. Now, by the way, I do recognize that I'm using the terms likelihood and probability interchangeably here, and that justifies me as, I believe the phrase would be, ignorant slut. But I can only say probability so many times before I start to drool. And honestly, I think they're close enough for this conversation. But by all means, go ahead and kick me out of the nerd club if you absolutely must. Now, speaking of beating people up, I don't want to beat up on the authors of this paper too much. I think they really did do a pretty good job with this paper. They did a double-blinded, placebo-controlled, randomized trial. They're really doing all the things. They performed a power calculation and they enrolled their needed sample size. And that's not easy. And they found statistically significant results that let them claim calcium pretreatment works, which is no doubt what they set out to show. But I think they could have improved the study by doing a couple things. Now, I know that's easy for me to say, and I also recognize that I am rapidly becoming reviewer number 2. I apologize in advance to anybody whose paper I might be reviewing, say right now. Now, what do I think they could have done to improve it, you ask? Well, I'm glad you asked that. First, they could have used a more clinically meaningful outcome, maybe like the proportion of patients experiencing post-treatment hypotension, or the proportion of patients with hypotension that required intervention. Better yet, I'd really like that. Now, second thing they could have done, they could have based their power calculation to identify this more meaningful difference. Now, I realize this almost certainly means they would need to enroll a much larger sample, and a larger sample is a larger pain in the ass. I get it. It means it's going to take longer. It's going to cost more money. I really do get it. That's hard, but it sure would have made for a better study. Now, finally, the third thing I think they could have done better, or at least done to better answer the question I want to know, and after all, this is all about me, they could have used a larger dose of calcium. Just stick it right in there with the 90, 180, or 273 milligram arms. Or better yet, just do the 273 and placebo, if sample size is an issue. I'm willing to help out here. Now, despite them not writing the paper that I wanted to read, it's pesky how authors can do that. Despite that, they have provided some very helpful data to help better understand our clinical question based on what the literature said that preceded the study. So some of the prior studies were positive and some were negative, but they were all pretty close to showing no difference. At best, I think we would have to say that before this paper, there was unlikely to be a difference in hypotension prevention between calcium pretreatment arms. That means our priors are neutral. 50-50, could go either way. Now, given the data in this paper and using a minimum clinically important difference at 10%, we can calculate that there is between a 10 and 13% chance of seeing this or greater difference. And that tells us that while it could be helpful, it's really probably not. All right, so how do I make use of this? Well, I do it by comparing it to the chances of harm. And fortunately, there seems to be very little evidence of harm considering all of the other literature and what we see in this paper. And we already carry the drug on our truck, so there's a minimum amount of training or new purchases, so the opportunity cost would likely be low. So balancing both the low probability of benefit with a low probability of harm, I think I'm probably just going to sit this one out. I'm not going to change my protocols based on this evidence, but I will remain open to changing my mind if new evidence emerges, perhaps new evidence that is powered correctly to detect a difference of what I care about, meaning hypotension. But it's possible that'll happen, and if it does, I'm going to change my mind if the strength of that evidence is sufficient to increase my posterior probability of a minimum clinically important difference in hypotension prevention. Well, how much do I need my posterior to increase to? Well, I would say I'd need to see it at least better than even. Now, better than even may seem like a low bar, but we're currently sitting around 10% probability that this works. So we still have a ways to go yet to get to 51. If you made it this far in what just might be my most nerdy episode yet, I thank you. I offer up the universal nerd salute. So I push my glasses that I'm not actually wearing up right now. Now, I would love to hear your thoughts on this paper. I'd love to hear your thoughts on Bayesian analysis in general, or about my thought process on using Bayesian analysis to interpret this paper. I'll admit I'm relatively early on in my journey down Bayes Avenue, and I'm still trying to collect my thoughts about it and get them into a working order. So please let me hear your thoughts. Just please don't yell at me about using likelihood and probability interchangeably. I know they're not the same thing. I know I'm a bad person. If you're not going to beat me up about likelihood and probability, then drop me an email at jeff.jarvis@flightbridgeed.com, or you can hit me up on the socials. On that platform formerly known as Twitter, I'm at EMS Lighthouse. And if you happen to go on new platforms like, say, Blue Sky, I'm at drjeffjarvis.bsky.social. Thank you all again for listening. Take care, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.